Hello, everyone. We'll be starting in 2 or 3 minutes.
Hello, everyone. Welcome to today's Phlebotomy Webinar on capillary puncture versus venipuncture, advantages and limitations to using capillary blood. This is Heidi Zunker, an Education Program Manager for Mayo Clinic Laboratories. Our presenter today is Dr. Brad Cairns, Division Chair of Clinical Core Laboratory Services at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function, or following the presentation, phone lines can be unmuted to ask a question. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn the phone over to Dr. Cairns.
Well, thank you, Heidi, for that introduction, and welcome everyone to today's webinar. Again, we're going to cover capillary puncture versus venipuncture, some of the advantages and limitations to using capillary blood in both infants and children and in adults. So I have no disclosures related to today's talk, and I won't be discussing any off-label usage. So what we're going to cover is capillary and venous and arterial blood, actually, the different circulatory compartments that exist and where we sample blood, and the uses and limitations in particular of venous, arterial, and capillary blood when we may want to sample one versus the other. We're going to talk about capillary blood and arterialized capillary blood for infants and children and how that can be used and some of the limitations and advantages. Talk about the use cases for capillary blood in adults. They do differ somewhat in terms of where there's an advantage to capillary blood use in adults. And then, again, summarize and have time for questions from the group, and there are a few submitted before the presentation today. So when we talk about, this is a phlebotomy webinar, and I'm a co-director of our lab services phlebotomy group at Mayo Clinic, and so obviously our business is in sampling blood. And when we talk about blood, it's a circulatory system, so it's a system, it's a circle, depending on where you start. Generally start in the heart, the right side of the heart. Blood goes to the lungs to have oxygen, pick up oxygen and discharge carbon dioxide. Goes back to the left side of the heart and out through arteries. Arteries will deliver that blood to capillaries, and capillaries are where in tissue oxygen is delivered to tissue, and tissue can deliver carbon dioxide, lactic acid, and other waste. That capillaries then are connected become veins, and the veins deliver blood back to the right side of the heart. So that's all of the places blood is in our circulatory system. And we have a number of places we sample blood from. So we sample blood from the heart, but mainly in the ICU and the cath lab. So our phlebotomists are not doing that, but there is the ability to sample blood directly from the right side of the heart or even the pulmonary arteries when that becomes relevant. As far as I know, there's no option of sampling blood from the capillary bed in the lungs. That might be interesting physiologically to understand partial pressure of oxygens that are in capillary blood and in the capillaries of the lungs, but there's, as far as I know, no option to sample blood from that compartment. Arteries we do sample from, and so peripheral arteries, in particular the radial artery, are accessible and can be accessed when needed, predominantly for arterial blood gas analysis, arterial ammonia, selected test, and I'll cover those in which arterial blood will be the preferred samples for lab testing. Most of our testing is done in the veins, so veins are easy to access, and with very few differences, lactate in some situations, ammonia in some situations, a partial pressure of oxygen, the major one where PO2 of venous and arterial blood differs and has different use cases, that veins are preferred because they're easy to access, and most part physiologically the concentration in a vein is similar to an artery. And then capillaries, so the content of substances, biochemical substances, cells, in capillary blood does reflect the local content available to tissues. And so in terms of PO2 lactate, it might be interesting as a physiological question to understand what the true concentration is in the capillary blood. But we need to remember we cannot directly sample capillaries. Capillaries are too small. We can go to tissues that have highly concentrated capillary beds in them, like the fingertip. The ear is one, the heel of an infant. But we're not directly sampling a capillary. So before we get to that, what is capillary blood? Venous blood is the reference value for most lab testing when we establish our reference intervals for our biochemical tests, our cell counts, our coagulation tests. We're considering venous blood to be the reference sample. That's what we're comparing capillary or arterial blood to. It's whole blood directly removed from the vein by a venipuncture or a venous catheter. Relatively easy to obtain compared to arterial blood. It does reflect the concentration of cells, analytes, proteins in blood available to the organs, the brain, the liver, kidney, the organs we're trying to assess the health of. There are a handful of instances, like for a diagnosis of diabetes. The American Diabetes Association specifically calls out that venous plasma glucose is the specimen that should be used to diagnose diabetes. Most other guidelines don't specifically refer to whether venous or arterial blood should be used, and again, in most cases they're nearly interchangeable, but maybe helps just to have background that, when we're talking about how good is arterial or capillary blood, the reference by default is a venous sample. A couple situations do require arterial blood instead of venous blood. Those would be the assessment of the oxygenation status. Are we getting oxygen from the alveoli of our lungs through to the capillary bed into arterial blood circulation? For that, we need to assess a peripheral artery by an arterial puncture or an arterial catheter to get a partial pressure of oxygen and oxygen saturation in arterial blood. The comparable venous blood, PO2 and oxygen saturation, doesn't tell us anything about oxygenation in the patient because the venous blood has the oxygen removed by the tissue already. And then, as I briefly referred to, both lactate and ammonia, there can be differences between arterial and venous, and some laboratories will define reference intervals separately for venous versus arterial ammonia and lactate. And most data actually suggests the differences are pretty small, And in some labs, they just choose to completely ignore this and have one reference interval for both, but just awareness, there can be differences for certainly POT, but there is a difference. There can be differences in arterial ammonia and lactate compared to venous ammonia and lactate. And then we get to capillary blood, the subject of most of this session today. Capillaries, as I mentioned, they're too small. We're not directly, unlike a vein or an artery, we're not directly accessing a capillary to get this pure specimen out that's flowing in the capillary. Capillary blood is we're puncturing tissue that's rich, and it has a rich capillary bed in it. And what we get out is this mixture of arterial blood and venous blood. That is, the capillary blood is this mixture of arterial and venous blood, but also some intracellular fluids. We're going to break some cells in the process, so we get this cell juice out. And we'll get some interstitial fluid. Interstitial fluid is the fluid that bathes the cells in between cells in our tissue, is this interstitial fluid. And so capillary blood, quote unquote, is not a pure blood specimen. We do not access the capillary directly, but we get this mixture of arterial blood, venous blood, intracellular fluid, interstitial fluid, and we use that to approximate the venous concentration of cells, of biochemical analytes for many things. Where does this not work? Well, because we're going to break more cells, accessing breaking of our tissue in the fingertip, earlobe, heel of an infant, to get this access, this capillary blood. Those analytes that are highly concentrated in cells, and biochemically, that's mainly will often be potassium, AST, and LDH, will be higher in capillary blood than in venous blood, and that therefore measurement of potassium, AST, and LDH in capillary blood may be relatively unreliable because we are breaking more cells to get capillary blood than we would to do a venipuncture or even to get arterial blood. We also have to consider there's interstitial fluid, this fluid that bathes the cells, and interstitial fluid is quite different from venous blood, arterial blood, or capillary blood. Interstitial fluid has no cells. And so because we're going to get some interstitial fluid every time we do a capillary puncture, cellular components may not work as well in capillary blood than in venous blood. And I'm going to show you, amazingly, hemoglobin and cell counts work fairly well in capillary blood, despite the fact that there's some amount of interstitial fluid which has no cells in it in every capillary puncture. Despite that, the modern techniques for the automated Lancets allow us to get a pretty good specimen and have pretty accurate cell counts. There will be more variability in cell counts from capillary blood than venous blood, and so we just need to know if you really need a really precise hemoglobin or cell count, it'll be a little bit more variable in capillary compared to venous blood. And then we have physiological effects. Glucose, we know that when we eat, the concentration of glucose goes up immediately in venous blood after we've taken glucose into our system from the gut into the liver and into circulation. But there'll be anywhere from 10 to 20 minute delay between the time the glucose goes up in our venous blood and when it goes up in capillary blood. And so that delay can cause problems when we're measuring capillary glucose in a non-fasting state. We can get inaccurate results simply because what we're trying to estimate is the venous glucose concentration, but if we don't wait long enough after a meal or glucose challenge, the capillary will be lower than the venous. So guidelines at Mayo Clinic, we do heel sticks in infants up to 12 months of age or 20 pounds. After that, we have to do finger sticks in adults. And so we basically have those two sites. In Europe and other countries, the earlobe is an alternative to the finger stick for glucose monitoring, capillary glucose monitoring. It's the other site on the body that's has a very rich capillary blood. It isn't done much in the U.S. because the devices are not approved for that purpose, but really talking about heel stick, finger stick, and earlobe as the major sites that have a rich enough capillary blood that you can get a consistent sample for capillary measurements. So we'll talk about the use case of capillary blood for infants and children. Blood gas and acid base certainly is a major one, and And I've already told you that if we get a venous specimen, we cannot assess the oxygenation in the patient. The PO2 in venous blood doesn't help us at all know whether the patient's getting enough oxygen to their tissues. The arterial blood does, but we may want to avoid arterial puncture in an infant. And in infants, because of the density of capillary bed in the heel and the fact that the skin is very thin, if we heat the heel of an infant, we arterialize that capillary blood. We make its constituents reflect arterial blood more than venous blood. And by arterializing that capillary blood, by heating the heel of an infant, we can get a sample where the PO2 will give information about oxygenation. So the normal PO2 of arterial blood in an adult is 80 to 100 millimeters mercury. The PO2 of venous blood is very low, 40 to 50 millimeters mercury, and gives no information to us about oxygen delivery in the patient. But the arterialized heel stick sample can be used to provide information about whether the infant is getting oxygen into the tissues. And they do need a separate reference interval for that, though. If you want to offer a blood gas sample from an arterialized specimen from an infant, you would go to a textbook most likely or a literature reference, because the reference intervals are different for arterialized PO2 versus arterial PO2. What about a finger stick sample? We have instances in our children's hospital where they do want to assess acid-base status based on avoid an arterial puncture or even a venipuncture by getting a capillary sample. Well, unfortunately, in children and adults, a finger stick PO2, capillary PO2, does not correlate at all with arterial PO2, so you cannot use this to assess oxygenation. So you can get some information on pH and bicarbonate and PCO2, but unfortunately you cannot assess oxygenation with a capillary blood gas sample in a child or an adult, only in an infant under 20 pounds or 12 months where you can arterialize the blood in the heel. What about other common biochemical measurements? I mentioned potassium is enriched in cells, and potassium is one of the most common tests we want to measure in the lab. So can you get an accurate potassium from a finger stick or heel stick capillary sample? And there'll be several slides on this, and I think the answer is maybe. It depends how much you're willing to, uncertainty you're willing to have in the potassium measurement. So here's one study, quite old now, where 40 infants had an arterial line and a capillary puncture, and the capillary potassium ran 1.2 millimolar higher on average than the arterial line. So yes, the potassium is higher in a capillary puncture compared to an arterial or a venous specimen. Why is that? Well, it's pretty clear. It's because there's more cell breakage, hemolysis, free hemoglobin in these samples. So we did a study trying to see if we could, by retraining our phlebotomists who were doing capillary punctures, get better samples with less free hemoglobin, therefore less cell breakage and more accurate potassium. And we really found we couldn't. So we looked at 45 samples collected by trained outpatient pediatric phlebotomists. We then retrained a group of those phlebotomists and had another 37 samples compared to 69 samples collected from an inpatient nursery phlebotomy group who did a lot of capillary punctures. But the average hemoglobin didn't differ between the three groups, so we really could not train out this free hemoglobin problem with capillary heel stick samples. Here's another study that just looked at the mean hemoglobin, and it does tend to differ. Younger infants are going to have more hemoglobin present in their samples, so it tends to be the newborns we want to get a capillary puncture and assess things like bilirubin, which actually work most of the time, or do that arterialized blood gas. But we need to be very cautious about measuring potassium at the same time with those samples because there's quite a bit of free hemoglobin in those samples in the early infancy. And here's one of the more interesting studies to me. This is kind of a, unique, interesting study. They in this study, what they did is they took a very large number, 300,000 venous samples, and a fairly large number, 2,600 capillary samples, and they measured the H index, which is the qualitative amount of free hemoglobin in samples, and they compared it to the average potassium they measured in samples with either no or some hemolysis. And so here again, I just turned on my pointer here. So we had, for the venipuncture samples, 80% of samples had no free hemoglobin at all. This is a semi-quantitative, so 0 was no hemoglobin, over 5 would be 4, and 5 would be grossly hemolyzed samples. So 80% of venous samples had no hemoglobin whatsoever. The average potassium in those was 4.0 millimolar. 14% or so of samples had a little bit mild hemolysis. In the mildly hemolyzed samples, the average potassium went up from 4 to 4.2, and then the 2 would be sort of a little bit more hemolyzed, still mildly hemolyzed, went up from 4 to 4.5. You look at capillary samples, you can see that the distribution is different, so only less than 40% of samples had no hemoglobin at all, and half of samples had either a semi-quantitative 1 or 2 mild amount of hemolysis. But the most interesting thing to me is look at the change in potassium with the same amount of hemolysis. Potassium average went from 4 to 4.5 in the capillary samples compared to 4 to 4.2 in the venous. And at semi-quantitative hemolysis, at 10% of samples had an H index of 2. The potassium was already up to 5 millimolar, quite elevated out of the normal range, compared to only 4.5 in venous. So this is really interesting. It tells us with the same amount of hemolysis, the potassium will change more in a capillary sample compared to a venous sample. And finally, the last thing on this potassium issue, it's sort of a pet peeve or passion of mine, you could say. We do offer arterialized blood gas samples for infants at birth, but we don't report the potassium. And this was our attempt to validate potassium in an arterialized capillary heel stick sample where we collect it in a capillary blood gas tube, run it on a blood gas analyzer. And normal potassiums are going to be in the 3.5 to 5 range for an infant. And you can see these values just sort of centered on about 6 millimolar, average of 5.7, and a range of 4 to 10 millimolar potassium in a healthy population of infants, which really told us that we could not reliably measure potassium in an infant when we did this capillary blood gas, this arterialized capillary blood gas collection. So we do not report potassium in our capillary blood gases. So sample of potassium in biochemical analysis, capillary samples contain more free hemoglobin than venipuncture samples because we're breaking more cells to get that blood. For a given amount of free hemoglobin in the sample, the potassium goes up more in a capillary blood compared to a venous sample. And so we choose not to report potassium in capillary blood gas or when we know that a sample, when it was collected by capillary puncture, we will not report the potassium. If you would like to do that, you certainly need equipment that will measure semi-quantitatively or quantitatively the amount of free hemoglobin. And given this data that the raise in potassium per unit of free hemoglobin differs in capillary blood, the lab may want to set a separate cutoff or acceptability for a capillary sample compared to venous or arterial, and might be more conservative in terms of rejecting or commenting on results that have mild hemolysis with a capillary sample, even if they may accept it in a venous. Most other biochemical tests work okay, and the AST, LDH would be 2 other examples. Lactate and ammonia, 2 additional ones I think I have later on that don't work that well with a capillary sample. Most other biochemical tests work fairly well. We have some tests in the lab like direct hemoglobin, where physiologically is not a problem, but analytically the hemoglobin interferes with what we're trying to measure optically. And so we do know that about 40% of direct hemoglobin samples collected by capillary puncture will get rejected in our lab. And so again, those are main limitations: potassium, AST, LDH, lactate, ammonia, direct bilirubin tend to be the main common biochemical tests that are problematic in a capillary specimen compared to a venous. So let's move on to cell counts. So I mentioned whenever we do a capillary puncture, we get some interstitial fluid. Interstitial fluid's got no cells in it. But amazingly, we still get very reliable estimates, cell counts, and hemoglobins from capillary samples. Capillary samples can be more prone to clot. And so this can be a problem, and I think that was one of the questions submitted. How do you mitigate this, or the advantages? And I'll show you a little script and approach we use in our practice. But again, clotted, if you do a capillary sample, is more prone to clot than a venipuncture, so you have to weigh that benefit and risk of recollection for the infant versus the fact that it's generally less painful if it's successful. Fully clotted specimens will be rejected by the lab and result in the patient being restuck. There's also a danger of partially clotted, so the lab doesn't see the clot, but a partial clot leads to erroneous cell counts, so that's a risk again for the lab. Use of a transfer device that contains the anticoagulant, EDTA, in the sample goes from the heel and immediately has anticoagulant introduced. These transfer devices may help reduce clotting. I'll actually show you some older data on that now. Here's capillary versus venous hemoglobin and platelet counts using a transfer device, and almost all the time we were able to get the capillary value for hemoglobin and platelet count within 10% of the venous. So this does work. We do see a higher redraw rate when we draw CBCs by a capillary puncture in the nursery, but in terms of analytically, surprisingly, it works quite well. We get reliable cell counts I kind of mentioned early on. If there's a situation where you need a very, very accurate hemoglobin or neutrophil count or platelet count, you know we're going to have more variability in the capillary versus venous. You may choose a venous specimen at that point. So what is our approach for capillary sampling for children? This is the outpatient approach. It's harder to do for inpatients because parents may not be there. For an outpatient infant or child who comes to our pediatric outpatient sites, if the total collection of blood is less than 1 milliliter, 1 cc, our phlebotomists are given kind of a script or a message to give the parents about we could try a capillary puncture or we could try a venipuncture depending on the parent and child, if the child's old enough, child preferences. And we try to briefly explain the advantages of each. So again, if we do a capillary finger stick or a heel stick on an infant, it tends to be less painful, less uncomfortable for the child. We have, if we're going to do a CBC collection, we have a higher chance of having to recollect that, even for a total or a direct bilirubin or a biochemical analysis. There may be a higher percent of having to recollect it versus a venipuncture where we will have a less chance of needing to recollect it, but may be more uncomfortable. We may have to restrain the child more for a venipuncture. In the end, what do we do in our practice? Well, most bilirubin testing in the nursery and as outpatient follow-ups in the first couple of weeks of life are done by capillary heel sticks. So we very commonly do total bilirubin by heel stick. Newborn screening is pretty much everywhere done by heel stick. We do a lot of heel sticks for CBCs in the nursery and in the special care nursery, the level 2 nursery. Again, our data suggests exactly what I've told you. We have about a 5 to 6% redraw rate for capillary CBCs versus when we do venipuncture, it tends to be a little lower. We don't do a lot of finger stick testing in children. Most children and parents of children who are old enough to sit still and get through a venipuncture procedure will choose to do that. So our capillary puncture in our practice is mainly limited to infants in the first 2 to 3 weeks of life. So what tests should not be collected by capillary sampling for infants and children? Again, potassium I mentioned. We choose not to report that. You could try to do it if you define an H index in your lab that you feel comfortable with that would avoid what we call pseudo-hyperkalemia, reporting falsely high potassium results. Lactate and ammonia would be problematic. Lactate, those both would tend to run higher and be difficult to handle appropriately in terms of getting into the right preservative, the gray top tube for the lactate, and for ammonia we need to cool that and get it to the lab very quickly to prevent false increases, so those would be problematic. Otherwise, biochemical testing works pretty well. I'm not aware, or we never evaluated liver function tests, AST, ALT, well, bilirubin we do, but I don't have any reason to believe they wouldn't work in a capillary sample. CBCs, I showed you, we explained, we do cell counts by capillary puncture fairly often, and they work surprisingly well, given that some of the content of that capillary blood is interstitial fluid, but not enough that it makes the cell counts inaccurate. Most of the time they're accurate. Coagulation, generally not. We're going to cover point-of-care INR in adults. Generally, in coagulation, to assess the coagulation state of a patient, you need venous blood or arterial blood. The exception to that is point-of-care INR for the purpose of warfarin monitoring, but because there are not a lot of children on warfarin, it's just not, we just rarely get capillary blood to assess coagulation in children and infants. So now we'll move on to adults. So the use cases of capillary sampling in adults does differ from infants and children. Again, there are plenty of adults who have a fear of needles who prefer not to have a venipuncture, but for the most part in healthcare, we just ask the adults to suck it up basically and say, okay, we'll put you in a chair and lie you back if you feel like you might faint, but most of the time we want to get venous blood from adults. And the situations where capillary sampling is useful in adult patients are when we have need for frequent sampling, when we need rapid turnaround time, so we want to do point-of-care testing, or when we're collecting in non-traditional sites. The coagulation clinic, perhaps a good example of that. And so what it boils down to in adults, our primary uses for capillary blood are going to be glucose testing and point-of-care INR management. So glucose testing, self-capillary glucose testing is common in the patient's home. Self-monitoring of blood glucose, SMPG, has been a hallmark in diabetic care for decades. It's a little bit controversial of benefit in type 2 diabetics, but again, patients can monitor their glucose at home. Patients are not going to do their own venipunctures and mail samples to the lab, so it's a setting in which capillary analysis has value. In the hospital, most of us use glucose meters in the hospital for glucose assessment. Facilitates glycemic control, measuring glucose frequently for either diabetic patients or patients at risk of hypo or hyperglycemia due to their illness. And so we do this often in the hospital. Two main limitations of capillary glucose measurement compared to venous are going to be the physiologic lag, so the fact that the venous glucose goes up and then 15-20 minutes later the capillary goes up. So when we treat with insulin or feed the patient or give glucose intravenously, we know the capillary measurement won't reflect right away the venous measurement. And then the physiologic lag can be extended or made more sort of the magnitude increased if blood flow and perfusion isn't appropriate. So when the patient's in shock, has low blood pressure, the difference between capillary and venous blood pressure can be magnified, and we can actually have very low, less than 40 mg per deciliter venous glucose, and considered a sort of an emergency to treat, and with the capillary normal glucose, just because the perfusion of the patient is slow. Therefore, that physiologic lag between venous and capillary gets magnified or extended. So limitations being physiologic lag related to interstitial fluid glucose and magnified in patients who are shocked, low blood pressure, or have tissue edema. So there's a number of publications showing out there that the accuracy of capillary blood at very low and high values is problematic in patients who have poor perfusion who are critically ill. There are 3 glucose meter devices approved for use in hospitals in the U.S. Only one of those 3 has had the FDA say it's okay to use that meter in capillary blood in critically ill patients. Even for the one device that was approved, it did not meet the predefined FDA guidelines for accuracy, but the FDA felt, well, given the choice of no measurement or a capillary measurement, it's better to do capillary measurement, but there are simply limitations to capillary blood measurement in critically ill patients who have poor blood flow or perfusion, these septic shock patients, low blood pressure, endemic patients. So moving on to point-of-care INR measurement. So that covers the use case for capillary glucose in the patient self in the home, self-management, and in the hospital, with limitations among capillary measurement in the critically ill patients. But what about point-of-care INR? Why monitor INR with capillary blood? Well, warfarin is the major drug we're talking about, the only drug we're talking about, the use case. I see I'll get to questions, yeah. The only use case is for warfarin monitoring. And warfarin has a narrow therapeutic window, so if you don't give enough warfarin, the patient's going to clot. If you give too much, the patient will bleed. And the right amount of warfarin, the therapeutic window, is relatively narrow. There's a huge amount of variability between patients in response due to genetics, drugs interactions, and comorbidities. And there's a delay. We need to give warfarin one day and then measure the INR the next day to see what effect the warfarin have. So there's a lot of reasons why this is challenging to monitor warfarin and why monitoring by point of care might be an advantage. The target INR international normalized ratio is 2 to 3. And when we get INR gets above 4.5, our risk of bleeding is tripled. When it gets above 5.5, our risk of bleeding has gone up 5-fold. When the INR gets over 6, we've had almost a 10-fold increase in bleeding. So that just shows that narrow therapeutic window that we need to get the right amount of anticoagulation, but not too much. The risk of thromboembolism will increase as the INR decreases below that 2 INR of 2. So what we want to do is keep all the patients between 2 and 3, and that can be very hard to do and require many, many dose adjustments early on in warfarin therapy. And anytime the patient's diet or health or they start a new medication, there's a chance that, again, their INR will change with the same dose of warfarin. So that makes monitoring warfarin therapy a challenge, and getting the patient in the right range as much as possible a challenge. So times at risk of becoming having too much warfarin or subtherapeutic, when we start therapy, when we change medications or diet, when the patient gets ill. Hospital discharge, changing providers are all times of risk where warfarin monitoring, lack of warfarin monitoring could lead to either bleeding or thrombosis. So we know that point-of-care INR programs work. We know the success and safety of anticoagulation with warfarin is contingent upon patient knowledge, education, and compliance, patients being aware of diet, medication effects, and getting their INR checked. Provider knowledge and experience. Does the provider remember to tell the patient, come back to the lab to do your INR measurement this week? And the whole system of care. Does the system automate reminders to the provider or the patient that it's time to remeasure their INR? And we know by moving that to point of care and having the coagulation clinic or having the patient measure their own INR at home, we eliminate a lot of variables in these systematic issues, knowledge, compliance, education to patient. All happens better when we do real-time education from measure INR and give the real-time education to the patient, as opposed to having patients come to the lab and then relying on the provider to convey the message at another time. And so there is data that time in therapeutic range, 2 to 3, incidence of bleeding and thrombosis will be time in therapeutic range better, incidence of bleeding and thrombosis less when we do point-of-care monitoring of INR coupled with real-time education of patient in adjusting warfarin dose. But does point-of-care INR work? And certainly we've had this amazing time of pandemic and time to ask a lot of questions, and I like to go back and sort of not take things for granted. And so to me, when I have an interest in point-of-care INR monitoring, publish some papers, to me it's pretty amazing this works. When we talk about biochemical and testing and cell counts, I already told you there's limitations physiologically, and but it works okay. Coagulation testing, the reference method is always going to get venous blood, immediately add a citrate anticoagulant to chelate all that calcium. In a very controlled way then on our coagulation analyzers in the lab, we're going to add back the patient's plasma, which has citrate in it, and a very specified amount of calcium and this thromboplast and this phospholipid mixture to activate the clotting pathway. And then we're going to optically measure in seconds the time for that blood to clot. When we do a finger stick INR, we do a finger puncture, which we know we're going to break cells, so little chunks of cell juice and lipid are going to come out of that finger. We're not going to chelate the specimen, so that blood with chunks of cells, which are going to initiate clotting, go into a strip. And on that strip contains the thromboplastin, the same substance we use in the lab. And then we can't measure blood clotting optically on a capillary. We have to use an electrochemical current change to assess the blood clotting. And so when I think about it, it's sort of amazing this works and correlates as well as it does. And it's a little bit of kind of a miracle that several companies have made capillary INR match the lab INR so well. So how accurate is capillary INR with that, given that you're trying to reproduce optical clotting reaction in the laboratory with a strip, electrochemical strip on the finger stick method? Well, many studies show that 90% or more of INR point-of-care INR results are within half an INR unit of the lab, but 5 to 10% will differ by more than one INR unit. So it isn't perfect, but it's pretty good. There is a need to pair the right point-of-care method to the lab method. Lab methods themselves will differ, so if you use both point-of-care and lab INR to manage the same population of patients, most practices now will want to assess which INR method, point-of-care INR method, will match my lab. Even with the limitations, even with the best INR methods for point-of-care, there are discrepancies, and actually warfarin dosing discrepancies are fairly common, where the point-of-care gives you a 2.5 would lead to one dose of warfarin. The lab says 2.2 would lead to a different dose of warfarin. But essentially what's happened with point-of-care INR is that the favorable positive outcomes associated with the immediate education and dosing adjustments do less harm than the inaccurate measurements due to this trying to reproduce this complicated optical clotting on a strip. And so overall the outcomes are favorable, but we do need to keep in mind there'll be discrepancies between capillary and venous or reference INR. All of the devices we use for point-of-care INR are only approved to monitor patients who are being stably anticoagulated on warfarin. So if we just want to assess is there a clotting disorder, we can't use the point-of-care INR method, and so that is only useful for warfarin therapy. Another downside or limitation to point-of-care INR, it is point-of-care methods, and this is true in general of all point-of-care glucose INR methods. They're more A1C, more susceptible to lot-to-lot variability over time. So it's harder for these manufacturers to keep the disposable strip cartridge device calibrated to a true reference standard than it is for laboratory test manufacturers. And this, some of you know, one of the methods, Roche Coagucheck, was subject to a recall about a little over a year ago. And this is our internal data showing on the left point-of-care INR versus lab INR. You can see there's a clear bias, and we got many samples differing by half a unit or more INR, and that was when Roche did the recall. When the Roche fixed the recall on the right, we were back to our steady state with point-of-care INR matching within a half an INR unit on all the samples we analyzed after the recalibration. So again, there's some risk to point-of-care INR that over time the device's calibration will drift Certainly you can have that with lab methods too. It's just more commonly observed with all point-of-care methods compared to lab methods. What about other use cases in adults? So hemoglobin A1C works fairly well. We do hemoglobin A1C capillary and method sampling and a point-of-care method in 2 or 3 different settings in our practice, and not all devices at the point-of-care work great, but there are at least 2 devices that have a lab quality A1C available from a finger stick sample. So A1C is certainly something that can be done point-of-care effectively with a capillary sample. Or it could be done in a lab with a capillary sample. Actually, there are a couple central lab methods that now are approved for capillary sampling. If the issue is you just have a child or a teenager needs A1C monitoring periodically, doesn't want a venipuncture, you can either at point-of-care or lab do capillary monitoring. Lipid testing works fairly well. It doesn't meet the National Cholesterol Education Program, NCEP, accuracy guidelines, the capillary methods, but it works fairly well for screening. And then sexually transmitted diseases, there are several, HIV and others, where finger stick can be done to measure antibodies to infectious diseases like HIV. So that's really the summary I have. Capillary heel stick samples are frequently done for infants in our practice. The use cases, the best use cases are this arterialization of a heel stick blood for blood gas analysis, can give you assessment of oxygenation, acid base. You can do basic chemistries on that same sample, sodium, most of the bicarbonate, sodium, pH. Most things. Potassium is problematic. We talked about direct hemoglobin. We do collect a lot of heel stick samples for total and direct bilirubin, but we do have to reject 30 to 40% of the direct bilirubin measurements because there's too much free hemoglobin. CBCs are also commonly done in our practice on children from capillary samples. In children, we once in a while, not often, do finger stick venous blood gas analysis on children to assess acid base. Again, you can't use the PO2 to assess oxygenation, but you in a finger stick from a child could do most biochemical measurements, and you could use venous blood gas to assess acid base. Capillary sampling in adults is limited primarily to these specific use cases where there's a different environment or a frequent and rapid turnaround time needed. Glucose, INR, A1C, lipids, HIV, sexually transmitted disease being some of the main use cases there. So I think that's all I have. I think there's one question submitted already. Does Mayo track the hemolysis rates of capillary samples specifically? We do not track. I have a rate of hemolyzed capillary samples specifically. We have an overall hemolysis rate. We separate that to inpatient. Outpatient, we separate it by NICU, by special care nursery, by setting, NICU, special care nursery, and ED. But we do not, as a monitor, track hemolysis in capillary samples specifically. I guess the closest we'd have would be the rejection rate for direct bilirubin, which almost all of our heel stick samples, and that's quite high. But in the vast majority of those cases, we're releasing the total bilirubin, and the provider decides just to cancel the direct, so we do not have to recollect in that instance.
Thank you, Dr. Karen. At this time, we would like to continue to take your questions. So if you would like to ask one through the phone line, you can press *7 to unmute your phone. And then once you've finished asking your question, you can press *6 to mute your line again. And then also you can submit a question via the chat function on the CenturyLink web application.
And there was one question pre-submitted about should you always wipe the first drop away for a capillary sample or when there are situations where this is not preferred. Yeah, so it depends if you're just collecting for a lab analysis. So for an arterialized capillary blood gas sample, you would not, because you want to, you're all heating the heel, and the whole purpose is to arterialize that blood. You want to collect that right away. If you're doing a point-of-care test like a glucose meter or INR, these tests are all, and talked about some of the physiologic differences. The tests themselves are designed to overcome that, so you have to follow the manufacturer's instructions. It can be very confusing. For INR, you do not wipe away the first drop. For glucose, you do, and that's just how those devices were designed. So unfortunately, there's not a universal rule. You probably need to look at the device you're using and determine whether the manufacturer instructs you to discard the first drop or not.
Okay, well, if there are no questions, then I would like to thank everybody for participating in today's phlebotomy webinar. Oh, actually, here one just was submitted, Dr. Karen.
So what's the accuracy of hemoglobin in a capillary stick in adult patients? We actually we just finished, it's an interesting question. So our primary use case for capillary CBC and hemoglobin is in infants, but when we evaluate new containers, so we use the MAP tube from BD, if anybody knows that particular micro container for capillary, it wouldn't be ethical to do those experiments on infants when we just want to validate a new tube. So we take lab volunteers, adults, and a finger stick in adults, and we find the same thing. The hemoglobin, the vast majority of hemoglobins will be within our accuracy criteria we define as within 0.5 grams per deciliter of a venous reference, and we can consistently get a finger stick sample in an adult with a hemoglobin within that tolerance. So we find the same thing, that finger stick cell counts in adults, which we don't do clinically that often, but we, as a matter of ethics and convenience, use the adults to validate new collection tubes. It tends to work quite well.
Okay, well, thank you again, everyone, for participating today. If you do have additional questions, please indicate them on the evaluation that will be forwarded to you here shortly. Note that laboratory credit is extended for this program. Upon finalizing your evaluation, you'll have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Please visit the education website for more information on upcoming education opportunities and a list of upcoming phlebotomy webinars. The next phlebotomy webinar will be on November 18th from 11 a.m. to 12 p.m. Central Time on quality metrics. Thank you again for joining us today, and have a great day.
Thank you. Please stand by.